Hello, welcome to the Best of ASCO Africa 2020. My name is Nwamaka Lasebikan, a clinical oncologist with the University of Nigeria Teaching Hospital, Enugu. Today, I'm going to be discussing abstract 4004, which is the final result from the IDEA collaboration. And the focus is on the overall survival and long-term disease-free survival of 3 versus 6 months of adjuvant oxaliplatin and 5-FU-based therapy for patients with stage 3 colon cancer. Now, by way of background, in 2018, the New England Journal of Medicine published the primary results on the duration of adjuvant chemotherapy for stage 3 colon cancer. This was a large study involving 6 collaborative working groups spread across 12 countries and accruing about 30 patients. The statistical analysis did not confirm non-inferiority of 3 months of therapy, and the study also generated lots of debates over the clinical interpretation, considering the huge reduction in toxicity that was observed. So the objective of the updated analysis is to evaluate the non-inferiority of 3 months compared to 6-month treatment for patients with stage 3 colon cancer for the secondary endpoint of overall survival with a pre-specified statistical hypothesis test. It was also to update the results regarding the primary endpoint of disease-free survival with mature data, median follow-up of 6 years, and to conduct pre-planned subgroup analysis regarding disease-free survival and overall survival. Now, the updated tumor characteristics were well balanced, and the ranges shown here refer to relevant differences among the 6 IDEA trials. Now, in terms of safety, we see here that there's a 3 times reduction in grade 2 and above neurotoxicity as seen in the 3 months versus 6 months of therapy, and this was statistically significant. Now, this is a non-inferiority trial, and the conclusions are based on some statistical assumptions. And this includes that the maximum acceptable loss of treatment efficacy was half of the gain on the mosaic. And the hazard ratio, the upper limit for the 95% confidence interval non-inferiority margin will be less than 1.1. And this corresponds to 2.26% absolute reduction in overall survival rate. Now, this is the overall survival of the overall population. Even though the curves appear to be superimposed, the hazard ratio is 1.02. And the upper limit of the confidence interval is 1.11. So the statistical conclusion was a failure to reject the null hypothesis after multiplicity adjustments. Now, in terms of subgroup analysis by regimen, we see that 3 months of CAPOX met its non-inferiority criteria. However, 3 months of FOLFOX did not. And then also by disease-free survival, 5-year disease-free survival by regimen, CAPOX also met its non-inferiority criteria, but 3 months of FOLFOX did not. Now, in terms of risk stratification, we see again that in the low risk group, the curves are yet again superimposed over each other, showing that there's little benefit in terms of duration and so met its non-inferiority criteria. However, in the high risk group, there is the difference is marked. So putting all of this together, in the low risk group, we see that the drug choice of FOLFOX 3 months therapy is okay, while the drug choice of CAPOX 3 months of therapy is okay. But in the high risk group, we notice that 3 months of CAPOX is okay, but there is a 1% loss of survival benefits. However, in the high risk group with FOLFOX regimen, 6 months of chemotherapy is required. So in summary, there was no loss of efficacy observed in low-risk cancers with 3 months of CAPOX. There was minimal loss with 3 months of CAPOX in high-risk group and 3 months of FOLFOX in the low-risk cancers. And there was relevant loss with 3 months of FOLFOX in high-risk cancers. The clinical conclusion is that the difference in 5-year overall survival between 3 and 6 months is minimal, if any, but the difference in toxicity is very large. There are also 2 distinct prognostic groups based on the T and nodal status, and there was a strong unexpected drug regimen between CAPOX and versus FOLFOX. The implications for clinical practice. 40% of patients are known to be high risk. And for the majority of these, the risk-benefit assessment suggests 3 months of CAPOX. For those unwilling to lose even 1 to 2% of efficacy, 6 months of therapy is recommended. Now, this has far-reaching implications for us in Africa, where most of our patients are high risk. And so with the 3 months of CAPOX as an alternative to the 6 months, there will be a reduction in the cost, both direct and indirect. There'll also be a reduction in the hospital stay, and there's also going to be a reduction in the loss of income with the 3 months when patients go on the 3 months of CAPOX. Thank you for your attention.